Good evening, everyone. How are you all? Welcome to Frustrated AMC MCQ, free 2-week sessions. We have been doing these 2-week sessions since last week, right? You had our trial sessions where we discussed the AMC introduction of MCQ, where you learned about how AMC MCQ works, what are the tips and tricks. You had a last session with me where I discussed how the exam questions appear, how to know what can be the tips, what can be the traps, what are the tricks. So you got to understand a little bit about AMC MCQ, right? Now, you are new, so things will not make a lot of sense still now. I'm sure like all of you are overwhelmed, stressed, you don't know what to do, and that's quite normal. Every one of our students, even me, when I started my preparation long ago, I felt the same. So initial first few months, it is going to be a learning process, and gradually you will get the idea that what's important, how to read, how to manage your time. So it will start to make sense. Right now, your part is that you listen to our classes, follow the guidelines that we are showing you, and make sure that you continue studying with us, continue the pace that we are giving you, make sure that you follow each and everything that we are doing. If you do that, in a couple of months, you will be a pro. So tonight, our session is focused on cardiology, and we will start cardiology theory, which we divide into 4 classes. 2 class is part of the free session, and then sometimes we might need to take 1 or 2 classes in the course to finish the full cardiology. So the most important topic for cardiology is chest pain, and every one of you will get questions from chest pain in the exam because it is likely to be a mastery question. So as you might remember when I talked in the trial session that mastery questions are something that you don't want to miss, because if you miss that, the chances that you will fail the exam, because mastery questions are not a lot in the exam. It is few, it carries high mark, and somehow we don't know which one is mastery question, but definitely chest pain, myocardial infarction, ischemic heart disease, this should be in the mastery questions. And you can get a lot of mark by choosing the right option or right answer in these mastery questions. But if you miss it, if you make it wrong, then you can also fail the exam very easily. So it's very important that you know the common things by your heart. You know each and everything about it. So let's start our tonight's session. Same, if you have any queries, anything that you don't understand, you can write it on the chat box. I always keep the chat box open. I'll try my best to answer all of your queries. So cardiology theory, we follow these researches. Now, today you will understand how our theory sessions work. And you know that you will get some random question solve session with us, which is basically just solving questions. For cardiology theory, your main book should be John Murtagh 9th edition. In the John Murtagh 9th edition, we have chapter 30, 58, 75, 76, 77. These are all the important chapters for cardiology from John Murtagh 9th edition. We follow a lot from therapeutic guideline. So a lot of things are not updated in John Murtagh, but therapeutic guideline is quite updated. So we will follow a lot of things from therapeutic guideline today. Kaplan step to CK nowadays with John Murtagh and therapeutic guideline, we normally don't follow Kaplan a lot. You will see in my note, there are still a few Kaplan step to CK notes are there, but we don't follow this a lot anymore. For any medicine related topic, you can search in as a RACGP guideline. Like you want to know something a bit more, like you want to know about aortic dissection. And you can just write in the Google aortic dissection RACGP guideline. So any medicine related topic, most of the important topics you will find out in RACGP guideline. RACGP guideline is quite updated, and a lot of questions come from RACGP guideline in the exam. The lecture note has each and everything that you need for cardiology, so you really don't need to go and read all of this by yourself. Okay? And once we finish the cardiology theory, then you can open a Q bank, any available Q bank, and then you can just go through cardiology questions from the Q bank and find out if you are able to answer the questions correctly. That's how you do your preparation for each of the subjects, each topic that we are going to do in the class. John Muttag 8th edition is not okay anymore because 9th edition, we have been doing it since last year. So 8th edition will not be okay. So today we will start with chest pain, which is chapter 30 in John Muttag. Okay, let's start then. So if we have got a patient who is coming with chest pain doesn't necessarily mean that it will always be cardiac. It can be a lot of other causes. So always keep an open mind that it's not that someone coming with a chest pain, it has to be a heart attack. It could be a lot of things. And most of the time, it is a lot of things. Now, for cardiac causes, most important thing to rule out is myocardial infarction. Then we should also think of, it could be just a simple stable or unstable angina, could be pericarditis. These three is usually the most important three causes which is related to cardiac. So cardiac causes of chest pain, myocardial infarction, could be angina, could be pericarditis. Vascular aortic dissection, very important. It comes in exam a lot, so we will discuss that as well. Respiratory. A lot of time, it can be a chest pain, but the problem can be in the chest or in the lungs. So any patient with acute chest pain, we should not forget about respiratory causes such as pulmonary embolism, pneumonia, we have got pneumothorax. Sometimes lung cancer is not a very common cause, but sometimes pleural effusion can come as chest pain. But these three is the most important to rule out. GIT causes, many times patient comes to us with just a gastroesophageal reflux disease, right? Or peptic ulcer disease, but they're coming with chest pain. So GIT causes are quite common, and we should not forget that, yes, GIT causes, the chest pain is a very common scenario. But again, any patient who has high risk, middle-aged patient coming with acute chest pain, we should always rule out myocardial infarction. That's the first thing that we want to rule out. It's the same thing that you will do in your life when you were a doctor in anywhere in the world. You always think that what's the worst thing that can happen to this patient, and you rule that out. That is the way to do it. And AMC also wants you to be the safest doctor. So they always test you in this way, that a patient coming to you with an epigastric pain, and the pain started since the last 3 hours. It's a 56-year-old patient. We know that epigastric pain, maybe it's just a simple peptic ulcer, maybe it's esophagitis. But if you don't rule out myocardial infarction, that is a mistake. That's a major mistake, because we know that sometimes MI can radiate to the epigastric area. So that we should always rule those out. So any patient who has chest pain, who has pain in the epigastric region, it's a middle-aged patient, it's an acute pain, we always rule out MI. Musculoskeletal, it's one of the commonest presentation of chest pain. Patient went to a gym, started doing gym or strength training after a long time, and then started to get pain in the ribs. So musculoskeletal pain is very common cause of chest pain. So patient can show to you that, like they can say that I have got a tender point on my chest. That is commonly musculoskeletal. If it is tender to touch, and patient can pinpoint the area of the chest pain, and you have got a classic history that I did some heavy lifting at gym, or I started doing some training, that's classic musculoskeletal chest pain. Also, it could be rib fracture, so patient got a fall or trauma, motor vehicle accident. Now the patient having pain in one or two ribs, and they will complain that whenever they take a deep breath, the patient usually needs to catch the breath because it hurts a lot when they take a deep breath or when they cough. So anything that causes a little bit of movement of the rib, because fracture rib means there is fragments of rib floating on the chest wall. So whatever causes a lot of movement of this fracture segment, it will cause pain, like deep breathing, coughing, even just movement, or even lying on that side, it will hurt. So that's fracture rib. There is also a neurological cause of chest pain. So sometimes patient can come to you with chest pain, and then plus there is a rash. So if a patient has chest pain plus a vesicular rash, which is fluid-filled blistery kind of rash, then you think of shingles or herpes zoster. All right. So these are our common causes of chest pain. So think about cardiac chest pain, vascular chest pain, respiratory causes, GIT causes, musculoskeletal causes, and neurological causes. Each and every chest pain is different in presentation. So understand the common things and remember the common symptoms for each of these so that you can easily pick up the likely cause. So if a patient comes to you with a left-sided sudden acute chest pain, and the pain feels like constricting, restricting pressure. Okay, so patient normally say that I feel like someone is sitting on my chest, or it feels like pressure or compressing. And the pain radiates to the left arm, right arm, neck or jaw. Along with that, they have associated nausea, vomiting, sweating. Plus or minus, they can have shortness of breath. That's the time we think of possible heart attack or acute MI. Similar kind of pain, but the pain lasting for few minutes. Let's say pain lasted for only 10 minutes, and it is always related to some kind of exercise or exertion. So patient was walking or maybe running, and then suddenly patient started to feel the similar kind of chest pain, same presentation, but when patient stopped and took some rest, the pain went away. So when chest pain is less, usually for short duration, ideally less than 10 to 15 minutes, and it gets better with rest, that's the time we call it stable angina. Okay? If the pain doesn't get better, then it could be unstable angina, it could be myocardial infarction. We can only rule or differentiate between them by doing some test, which we will discuss later on. About pericarditis, pericarditis has some different presentation. Patient with pericarditis, they will come to you with a sharp, stabbing kind of chest pain. Pain can be felt in the central chest or in the left side of the chest. But they have a classic presentation that the pain get worse with deep breath, so inspiration. Okay? And pain also get worse when they lie down. So lying down and inspiration will make it worse, and pain will get better when they lean forward. And definitely there will be no radiation of the pain to the neck, jaw, or arm like MI. So pericarditis, classic presentation that patient had a recent viral illness, and then 1 week later, patient developed this sudden onset, sharp stabbing chest pain, maybe central or left side. And then it also says that the pain get worse when they lie down and better when leaning forward. That's a classic pericarditis. Okay. Now, aortic dissection, patient will come to you with a excruciating, sharp, severe chest pain, and pain is usually central chest pain. But a very important clue is that the pain will radiate to the back. Okay? So it's sudden, excruciating, sharp, central chest pain that goes to the back. Then we think of aortic dissection. Respiratory causes, the most important thing is if you get a patient with pleuritic chest pain. So what do you mean by pleuritic chest pain, guys? Pleuritic chest pain is that pain that gets worse with inspiration or deep breathing. So with deep breath or inspiration, if a pain gets worse, that's pleuritic chest pain. And pleuritic chest pain, all of this, pulmonary embolism, pneumonia, pneumothorax, all of them will have pleuritic chest pain. So that's the most important thing that you will look at when you are reading the question. Apart from that, pulmonary embolism will have a lot of other features. So they will get definitely chest pain, they will have shortness of breath, they can have palpitation, they will have some kind of risk factor, like maybe previous history of clot, like deep vein thrombosis or pulmonary embolism. Family history can be there. Maybe they had a long flight and they slept the 12 hours flight and ended up getting a DVT, caused the pulmonary embolism. So there will be always a risk factor. Now, this will be discussed in detail in our respiratory class. I will not go into much detail. Pneumonia, patient will have fever. They will have cough. They will have shortness of breath, and they will have chest pain. Classic tetrad of pneumonia: fever, cough, shortness of breath, chest pain, which is pleuritic chest pain. Pneumothorax, patient usually have chest pain, and it's sudden onset chest pain with shortness of breath. Many times patient might have history that they are very lean and thin, tall patient. Sometimes it could be just a spontaneous, like there was no known cause, it just happened, which is the commonest one, which we call spontaneous pneumothorax. Sometimes pneumothorax can happen after motor vehicle accident. Sometimes it could be in a patient who has asthma, COPD, or they have pleural bleps or sacs, and the sac can rupture and can cause pneumothorax. So there is always some kind of reason for having this embolism or pneumothorax. Sometimes for pneumothorax, there might not be any known cause, it just happened. All right. So these are our respiratory causes of chest pain. Again, this will be discussed in detail, not today, but in RESPI class. GIT, it's very common that if it is a GIT related chest pain, the pain will be burning chest pain. So patient will say, I'm getting a burning central chest pain. With that, you might also get features of reflux. So they can say, I'm getting a lot of reflux, I'm getting a lot of heartburn, or my mouth get full of saliva. It get worse when I lie down at night or bend forward. That's gastroesophageal reflux disease. If it is peptic ulcer, they will have epigastric pain. Musculoskeletal, we already talked about it, and neurological, we also talked about it. Did it make a little bit of sense? We will go in detail about all of them, but I just wanted to give a summary of how to pick up the main causes of chest pain in the exam. Because if you can remember at least this, you will know that what kind of chest pain it is. What is the cause of chest pain in this patient? All right? So everything in here, it's discussed the causes of chest pain. So we discussed about aortic dissection. You can see pain will be sharp, tearing, extremely severe, radiates to the back. Pulmonary embolism, same thing. It will be pleuritic chest pain. Patient will have dyspnea, tachycardia, hypoxemia. That means the saturation will be low, the pulse rate will be high, and patient will have shortness of breath with pleuritic chest pain. Pericarditis, we say that it can be preceded by viral illness and the pain is sharp, pleuritic, relieved by leaning forward. Sometimes we can get pericardial rub on auscultation. So this is a table of all the differential diagnosis of conditions which causes chest pain. You can go through that in your own time, but I have already discussed the important part from here. So let's say we know the causes of chest pain or differential diagnosis of chest pain. So once we know that, our next step is, what are we going to do next? What is the investigation? Any patient coming with sudden onset chest pain or epigastric pain, we will need to do a ECG right away. The next step is ECG. Okay? The ECG might be normal, or ECG might show some abnormality. What abnormality we are looking for? We are looking for whether there is any ST elevation. So ECG is not a part of the free class. Once we finish this free 2-week session, the first class that we will take is the ECG. So you will learn a little bit more about what is this ST elevation and everything in that class. But for now, just know that ECG can be normal, or they can also have that classic ST elevation. Now, if a patient has sudden onset chest pain and you have done an ECG and the pain is lasting for, let's say, 30 minutes, if the ECG is normal, will you stop there or will you do something else? Will you send the patient back home? No, you can't, because one, that ECG can change over time. The patient who did not have any ST changes in half an hour, they can have ST changes maybe in 1 hour or 2 hours. You never know. That's one thing. And the next thing is that it's not always that patient will have a ST elevated MI. They can have a non-ST elevated MI. So if you don't do any further test, you will miss that particular thing. So even if a patient has got normal ECG, but if a patient has got active chest pain, you will need to do a cardiac enzyme, which is basically the troponin, to rule out any possibility of a non-ST elevated MI. All right. So what are the cardiac enzymes that we have? We have got CKMB. We have got cardiac troponins. That is usually the most common thing that we do. We don't do the CKMB, very rarely we would do it. And then there is another one called myoglobin. These are not commonly done anymore. So now the troponin is our main options. So you can see the troponin can take 4 to 6 hours to become abnormal. So that's one of the important questions that come in exam, that you have got a patient who has chest pain and it started 4 hours ago. Okay. And then patient presented to the hospital, you did a ECG. The ECG is normal. Then you did a troponin. Troponin also came as normal. Will you just let the patient go? Patient still have got chest pain. No, you can't. So the next step is serial ECG. So you have to do serial ECG plus serial troponin. Okay, so every couple of hours, you will do ECGs to see that if there is any change. Every couple of hours, you take the blood, check the troponin, whether it is getting elevated or not. So that is the way to go. Now, once troponin gets elevated or abnormal, it will be abnormal for 10 to 14 days. Whereas CKMB also take 4 to 6 hours to get abnormal, but it lasts elevated for just 1 to 2 days. The question is that if someone has got myocardial infarction and you found troponin is elevated and you treated the patient, but even after treating a MI, they can get a reinfarction. Now, the troponin will stay elevated for 2 weeks. You cannot rely on troponin during that time. So what will you do if you want to rule out reinfarction in a patient within this timeline? What will you do? That is the time you will order CKMB, because CKMB will be elevated just for a couple of days. So for a patient who had a recent infarction, and if after treating that, if you find out that the patient again complaining chest pain and you want to rule out reinfarction, that's the time you can order the CKMB. That is the only time we will order it. Otherwise, nowadays we don't do, myoglobin is out of the picture long ago, and CKMB very, very rarely we would do it. Okay? We are coming into the management, Rono Shah. So without ECG and troponin, we will start aspirin. Yes, we will start aspirin if we are suspecting a cardiac issue, but we'll come into that just in a few moments. Now you might be asking that, yes, good question. So can we do troponin for patients who had reinfarction? Yes, we can. Nowadays, that troponin can be done as well, because nowadays the pathology can use a percentage. So if we see that there is a sudden jump of percentage, let's say like there is a 20% increase of troponin since the last troponin, even after treatment, that is the time we can rely on the troponin. Okay, so it can be done as well. So troponin, CKMB, both can be done in that case when we have the reinfarction possibility. It is not a common presentation that patient will have reinfarction, because most of the time when we put the patient in, let's say, cabbage or stent, very unusual that patient will have a reinfarction, but again, it can happen. Then we can either do the troponin or we can also do the CKMB. But if we do the troponin, we will need to look at the serial change of, like, what was the troponin before treating the patient, and now after treating the patient, if this troponin has jumped more than 25% than the previous troponin, then that can indicate that patient has got reinfarction. All right. So, okay, I understand like you are asking about which one is the preferred. My we still prefer troponin in everywhere. If troponin is an option, we will go for troponin in the first place. Okay? Because one thing is that we have the troponin initially because we have diagnosed the patient with heart attack based on that troponin elevation. And then we can easily measure the troponin again after the treatment if we are suspecting reinfarction. So the the guideline is that both can be done. CKMB, we can do it. We can do troponin. But if you're asking me that which one will be best or preferred, that will be troponin. Always, troponin is the best for any kind of infarction. It was not the case for a long time. Long time for reinfarction, we were relying on CKMB only. But nowadays, the pathology are very advanced and they can easily check it. Okay. All right. So we have got this CKMB and the troponin thing going on. Now, what else we can do? If a patient come to us with chest pain after ECG, is there any other test that you would like to do? And after troponin? Yeah. So there are a lot of things that we can also organize. So if we, and now that it depends on your other differential diagnosis. So if you think that this patient might have pneumothorax or pneumonia, then yes, chest X-ray will be important. Or if you think about aortic dissection, it is important. If you're thinking of pleural effusion, all of them, you can find some clue in the chest X-ray. All right. Now, one other thing one of you asked me just a few minutes ago that what do you mean by serial ECG and serial troponin? So what is serial ECG and serial troponin, guys? We talk about it a lot, but what it is, do you know, any of you? Ideally, we say that if we find out that usually if you draw the final blood at in between 3 to 6 hours, depends on a lot of factors, depends on if the patient has got the chest pain, if the patient has got uh, high risk factors, high blood pressure, diabetes, high cholesterol. In that case, we will prolong it to 6 hours. So at 6 hours, still ECG is normal, still troponin is normal, you can safely rule out myocardial infarction. So every 2 hours, since the patient arrived, you will do the repeat ECG and troponin. And at 6 hours mark, if you find out that there is no change in the ECG or troponin, the patient can safely, you can rule out myocardial infarction in that patient. Okay? And sometimes if patient doesn't have any chest pain, it's a young patient and no other risk factor, you can even send the patient home in 4 hours time. Okay, so it depends. So it's in between 4 to 6 hours based on the presentation, symptoms, comorbidities, etc. Did it make sense to everyone about this tests and investigations, because these confuse a lot of people. This is confusing. There is not a lot of guidelines about it, but now it should make a lot of sense, I hope. Next. So when a patient comes to us with chest pain, we always think first that it is likely to be a myocardial infarction until we can prove it otherwise. So what are the risk factors for ischemic heart disease? So the single most important reason or single most important cause of ischemic heart disease is elevated LDL cholesterol. So hypercholesterolemia, and among the hypercholesterolemia, high LDL is the single most important group that carries the risk of ischemic heart disease. So remember this, single most important is LDL cholesterol. The worst risk factor, so someone who has got diabetes and also got cardiac issues, they has the worst risk factor. You all of you must know that in a patient who is diabetes, who is diabetic, if they get heart attack, that is always a risk factor. So worst risk factor for coronary artery disease is diabetes, and the most common risk is hypertension. So three things: single most important risk factor, LDL cholesterol; the worst risk factor is diabetes; and the most common risk factor is hypertension. Important. Which one of the following risk factor for coronary artery disease will result in most immediate benefit for the patient? So sometimes, time to time, you will end up getting this kind of questions in the exam. So the single most important thing, like if patient do one of these five, they will get immediate benefit, which is smoking. So if a patient can stop smoking, smoking is a major risk factor. So, and if they stop it, it can give immediate benefit for the patient. So a lot of things to remember in these kind of questions. So what's the single most risk factor, most important risk factor? What's the most common risk factor? What's the worst risk factor? And what can give us immediate benefit if patient can manage it? That's stopping smoking. Let's talk about myocardial ischemia, which is the most important topic for chest pain. So patient with myocardial ischemia, we know that the pain can be felt in anywhere you can see on the image. The most common presentation is left-sided chest pain. It can be felt in the epigastric region. It can even be felt in the back, so in between two shoulders. It can be felt in the neck or jaw. You have an idea that the myocardial infarction chest pain always radiate to the left arm. Actually, no. It can radiate on both arms. And right arm is more specific for myocardial infarction, not left arm. So just because someone is coming to you with a sudden onset left-sided chest pain radiating to the right arm, do not rule out myocardial infarction because of that, because it is very common for a MI patient to come with a chest pain which is radiating to the right arm. Okay? Now, it's all written in here. We know about this pain. The quality of the pain is usually described as pressure, heaviness, or tightness. So it's important to know the character of the pain. The radiation is important. So find out what makes it worse. We know that cardiac pain will get worse with exertion. If it is respiratory causes, that pain usually will get worse with deep breathing or deep inspiration. Myocardial ischemia patient, apart from the chest pain, they will have associated shortness of breath, dizziness, nausea, vomiting, and sweating, as we already know. Three things should come into your mind when a patient comes to you with a chest pain. So it could be like the classic chest pain. So it could be a stable angina. It could be unstable angina. and then it could be myocardial infarction. So if a patient comes to you with cardiac chest pain, so that you know how the pain will feel like, then you will need to think of, is it a stable angina? If it is a stable angina, the pain will be same, but it will usually last for average 3 to 5 minutes. It will be relieved by rest, and if patient takes GTN, which is nitroglycerin spray or sublingual tablet, it will get better. So that's stable angina. Excuse me, guys. Then unstable angina, it's very difficult to differentiate unstable angina from myocardial infarction based on the symptoms only, because both of them will not get better with rest. So unstable angina is angina that will last for 15 to 20 minutes or even more. The pain will be similar kind of pain. Same with MI. MI pain also will last for more than 20 minutes. And we know that MI pain, the pain will be very severe. Patient will have shortness of breath and all the other symptoms that we talked about. So by symptoms, you cannot differentiate MI and unstable angina. Okay? So how to differentiate between these two? We'll come into that just in a moment. So please go through this characteristic of the ischemic heart disease chest pain. We know that the cardiac chest pain will get worse with physical activity, cold, and emotional stress. So stress, exercise, physical exertion will make it worse. We know all of these associated symptoms. Quality of the pain is really important. Squeezing, tightness, heaviness, pressure. Burning is usually not a common symptom. And sharp, stabbing, knife-like, this is not a cardiac chest pain. Sharp, stabbing, knife-like is usually pericarditis chest pain. Okay? If you look at this picture, you can see that this is how we differentiate the ischemic heart disease. A lot of patients, they might not have any symptoms. Especially in earlier stages, they will not have any symptoms. When a patient starts to get the symptoms, which is the chest pain, then we think of, is it a stable angina or is it acute coronary syndrome, ACS? Stable angina, we know that patient gets chest pain with exertion, and when they take rest, the pain gets better. And you can see that this is a coronary artery. It has atherosclerotic plaques, but it's open. It's not fully blocked. Okay? So when they're doing something exertional, then the body cannot keep up with the oxygen demand because it is already narrowed. That's why they get the chest pain. And when they take rest, body can keep up with the demand. In acute coronary syndrome, the plaque can get ruptured and it can completely block the coronary artery. That's why the pain can last for a longer time. And we divide the acute coronary syndrome into unstable angina, non-ST elevated MI, and ST elevated MI. So how we differentiate all of this? First, you do the ECG. If ECG shows ST elevation, that's quite easy. It's a ST elevated MI. And what is ST elevation? So if this is your P wave, and that's your Q, R, S, T. This is normal. You can see the isoelectric line. So all of these are in the same line, and that's your ST wave. Now, if we look at this one, so what we see here that this is where the ST is now. So that's where it should be, but you can see the ST is now elevated. That's what we look for. Same in here, you can see there is a ST elevation. Now, if there is ST elevation, it's ST elevated MI, but if it is not ST elevation, then it could be unstable angina or it could be non-ST elevated MI. how to differentiate between an unstable angina and non-ST elevated AMI. That is the time the cardiac marker, which is the cardiac troponin, will help you to differentiate between these two. Troponin will be elevated in non-ST elevated AMI, and if troponin remains normal, that will be unstable angina. Nice and easy, everyone. It should be very, very easy for you at the moment. All good? Everyone cruising along? It's not complex discussion yet. There will be some complex later on, but I hope it's making sense. Yeah, okay. I have added few things about the difference between unstable angina and non-ST elevated AMI. You can go through that. One of the important thing is unstable angina doesn't cause any necrosis of myocardial muscle. That's why we don't get elevated troponin. Whereas in non-ST elevated AMI, the myonecrosis has already happened. That's why we get the troponin elevated. Okay. No, it is not all from John Murtagh. It's a combination of all the things. It's a combination of John Murtagh, Kaplan, RSCGP, therapeutic guidelines. So it's all together. Now, this is from John Murtagh. So a stable angina, we know. Unstable angina has a lot of pattern. So one of the important thing is that sometimes unstable angina can even occur at rest. So just because if someone say that I was just sitting on the couch or I was sleeping and I woke up with chest pain, do not rule out cardiac chest pain because of that. Because unstable angina can happen even at rest. Okay? So you can see that it is increasing angina over a short period of time precipitated by less effort. So even a little exertion can bring it, may even come on at rest, especially at night. So it's important to know that we always think that if a patient has got pain with exertion or activity, that is heart-related condition. We just completely rule out the possibility that if someone was taking rest, especially at night, they can have a chest pain related to ischemic heart disease. So this is where it becomes a bit complex, and do not rule out possibility of a angina if the patient complaining chest pain even at rest or at night. So that's nocturnal angina. Sometimes patients say patient gets the pain when they lie flat and relieved by sitting up. That's called decubitus angina. There is another angina called Prinzmetal angina, which is not myocardial injury. It is related to coronary artery spasm, which means that there are some patients where their coronary artery can get into sudden spasm, and usually it occurs at rest without any apparent cause. There is no reason why it happens. But their coronary artery, if this is a normal coronary artery, their coronary artery becomes narrow like that. So when it is a spasm like this, there is quite a lot of narrowing of the coronary artery, which causes lack of blood supply, and patient can present to you in the same way how a MI patient presents. So they will have typical chest pain. Even you will get ECG showing ST elevation. So chest pain that occurs at rest without any apparent cause, and you've got ST elevation, what will you do next? You will treat this patient as if they have got ST elevated MI. But this will be diagnosed when you're going for the coronary angiogram to look into where exactly is the block. You will find out there is no block. That's how we confirm the diagnosis of Prinzmetal angina or variant angina. So these are some of the variation of chest pain. So we already know that, first of all, we will go from stable angina management, and then we go to the myocardial infarction management. So what are the investigations for a stable angina? First, we do ECG. By the time patient comes to you with a chest pain, their chest pain will be all gone. So they will say that I was walking I was walking with a mate, and then suddenly I started feeling a bit of a chest pain on my left side, and then I stopped, took some rest, and the chest pain went away after 5 minutes. So by the time they come to you, they have no problem, they have no symptoms, but still you will do a baseline ECG, and you will find out that ECG is normal. Okay, but sometimes if you can get the patient during an attack, you can get symptoms, you can get ECG changes. And what are the ECG changes that suggest ischemic heart disease in a patient? So that's what we look for. We look for any ST segment depression. So you can see the ST is depressed. Normally T wave should be like this, but if you see a patient having T wave inversion, and it's more than two to three contiguous leads having the same thing, not just a single lead. It has to be at least two or more contiguous leads showing the similar pattern. Then you can think of ischemic heart disease. Okay, so these are some of the ECG changes that we can get in a patient with stable angina if we can do the ECG during the attack. When the patient's chest pain subside, most of the time the ECG will be completely normal. So how we can find out that if this patient has got any underlying ischemia? That is the time the stress test will be important, because you need to stress the patient's heart to find out whether during a stress the ECG shows some changes. Does it make sense? Guys, are you good? Are you under? So first, when a patient, so remember we are thinking about a stable angina. So we did ECG because patient complained of chest pain during exertion. Now the patient is fine. We did a baseline ECG. ECG came completely normal. Will we just stop there? We will not do anything else? No. Now we should send the patient to a stress test to find out that what will happen, or can we find out any ECG changes when the patient is under stress. So that's why we call it a stress test. And there are a lot of stress tests. For different group of patient, we offer different type of stress test. Let's talk about it. The most common one that we do is exercise ECG, or also known as exercise tolerance test, ETT. There are a few others. We will talk about that, like thallium scan and all. So first talk about a stress test. So exercise tolerance test means that you will ask the patient to run on a treadmill, and while the patient is running on a treadmill, first you look for any chest pain, any symptoms, and you also look at the ECG, and you look for whether there is any ECG changes like ST depression or T wave inversion. So this exercise tolerance test, or ETT, if you can only do it in these two situations. One, that as a baseline, there was no abnormality. So when you did the baseline ECG, there was no problem in that ECG. There was no bundle branch block. So the ECG was completely normal. So if ECG was completely normal as the baseline or resting ECG, and patient is able to exercise, you can't send a patient who is 80-year-old to run on a treadmill, or someone who is waiting for a knee replacement or hip replacement because they have got advanced degeneration. You can't send them for running on a treadmill. So you have to also know your patients, their comorbidities, and choose the right test for them. So two factors are important. Is this patient's baseline ECG normal? Yes. Can this patient run on a treadmill? Yes. If that is the case, then we can send the patient for an exercise tolerance test. If exercise tolerance tests come back normal, you can safely say that there is nothing wrong in your heart. Now, what if there was some baseline ECG abnormality? So if there was a baseline ECG abnormality, then you cannot do the exercise tolerance test anymore. This is where it will become a bit complex. So please try to follow. When there was baseline ECG abnormality, then we have two options to detect ischemia. So we have nuclear scan, which is thallium scan, or we can do echocardiogram to detect any wall motion abnormalities. So what does it mean? So in nuclear scan, the patient will be given a nuclear dye, and the dye will go into the blood vessel, and it will reach the heart. And when it reaches the heart, the dye has to go through the coronary arteries to reach different part of the heart. Now let's say there was a blockage on this artery. So this side of the heart will not pick up the thallium or the dye similar like the other part of the heart. So let's say that this part, which was supplied by this coronary artery, did not pick up the dye like the other part of the heart. So this gives you an idea that most likely there is some blockage in this side of the heart. That's why the muscle did not take the dye like the other muscles. So it gives us an indirect idea that there is likely some kind of ischemia going on. Yes, that's commonly in Australia, we call it myocardial perfusion scan, MPS. Then the other one is echocardiograph detection of wall motion abnormality. So when we do echocardiogram, during the echo, we can see that if the heart, all the ventricles, atrium, if the wall of the heart is moving symmetrically or moving in a normal way. Patient, let's say that someone has got some, let's say that left side, so someone has got ischemia of the left coronary artery. Could be left anterior descending, could be left circumflex. So any of the artery has got a bit narrowed, maybe 70% block, or let's say 50% block. So what will happen that because of the blockage, that part of the heart, let's say the ventricular wall, will not move in a normal way, which we can say that the left ventricular wall is having akinesia or hypokinesia, which means that it's not moving normally. And why it doesn't move? If it is not getting enough blood supply. So again, it gives us an idea that something is wrong in this side of the heart, so there must be a blockage there. Right? So we can either do the myocardial perfusion scan, or we can do echocardiogram to check for these wall abnormalities. So that's all discussed in here. Now, is there anything better? Both of them are equally okay. So usually exam will not ask for this, that choose between the nuclear myocardial perfusion scan or echocardiogram. If you really need to choose, the MPS will be much better, because echocardiogram, it is dependent on the radiologist or radiographer. So it is kind of a subjective, but this one is not subjective. So MPS is better than the echocardiogram, but they're equally important. Now, so you've got this, that if a patient has some baseline ECG abnormality, then we have the option of either doing the thallium scan, or we can do the echocardiogram. Remember, these are all stress tests. So patient will run on a treadmill during this test. Patient will run and they will do echo. So these are called stress echo, or these are all stress tests. This patient can run. What if the patient cannot exercise? In that case, you cannot ask the patient to run on a treadmill. So you will still need to stress the heart. So this is where we do the chemical stress. So we'll use a chemical which can work in the same way as if the patient was running on a treadmill. So that's the time we can use dipyridamole or adenosine with the thallium scan. So with the thallium dye, we will also use any of this chemical like either adenosine or dipyridamole. That becomes a chemical thallium test. In the same way, instead of asking the patient to run on a treadmill, we will do echocardiogram after giving the dobutamine, because dobutamine will increase the myocardial oxygen consumption, and it will work in the same way as if patient is running on a treadmill. So to summarize everything that we have done, first of all, if a patient, we suspect they have a stable angina, so let me just draw this, it will become easier for you. This is where a lot of candidates get confused. I know why it is, but I hope after today's discussion, it will become easier for you. And it comes in exam. So we've got a patient with stable angina. We did ECG, which is a baseline ECG, and baseline ECG was normal. Okay, so now we want to do a stress test. If the baseline ECG normal plus patient can exercise, excuse me for my handwriting. In that case, we can go for exercise tolerance test, which is a stress test. Okay, so stable angina, baseline ECG was normal, and then in that case, we want to stress the patient. So we will find out ECG normal, patient is able to do exercise, to send the patient for exercise tolerance test. Now the problem is, let's say the ECG has some baseline abnormality. Means they might have bundle branch block, maybe heart block, something abnormal. In that case, we either do a stress echocardiogram, so patient will run and we do echo, or we do the myocardial perfusion scan, which is also known as thallium scan. So in this case, patient will still run on the treadmill. But what if patient cannot exercise because they have got some musculoskeletal issues? If patient cannot exercise, then we do chemical stress test. And the chemical stress test, we have dobutamine, thallium scan. So you give the dobutamine and the thallium and then do the nuclear scan. Or you can do same dobutamine echocardiogram. I hope it makes sense. Same, either dipyridamole or dobutamine. It can, like, we can use either, doesn't matter. Troponin has nothing to do in stable angina. Remember, okay, we don't do troponin for a stable angina patient because by the time patient is with you, their chest pain is already gone. So there is no point of doing a troponin in a patient who doesn't have a chest pain. Now, so far we know about all these tests. So let's say the test came as abnormal. So you have done any of this stress test as above. Doesn't matter, maybe exercise stress test, maybe chemical stress test, or just a simple stress echo or nuclear test. Whatever stress test you have done, What if it came back abnormal? So when it comes back abnormal, so patient has got some kind of ischemia going on, then you need to confirm that. The only way to confirm it is by doing a coronary angiogram. With the coronary angiogram, you can detect where exactly is the block and how much is the blockage. So we say that if it is 1 or 2 vessel disease, which means that someone has got 70% block of 1 or 2 coronary arteries. In that case, the treatment is usually just putting a stent to prevent any kind of coronary attack or coronary syndrome in the future. If they have got 3 vessel disease, or it's a diabetic patient with 2 vessel disease, they will go for coronary artery bypass grafting. So that's the step-by-step management for stable angina or ischemic heart disease. Everyone clear so far? So you can see that this is how the coronary angiogram works. See that they put a dye and we can find out that definitely this artery is having a bit of a blockage. We can see this artery has blockage, this one. So you can easily find out. And the test will say how much is the blockage. These are all the indication of coronary angiogram. You can read that. Management. Two vessel disease means that 2 branch of the coronary artery has got 70% blockage. Yes, yeah. During angiogram, a stent can be placed at the same time if it is indicated. If we are doing so there are 2 types of angiogram. We have a non-invasive CT angiogram, which is CT coronary angiogram. Okay, so that's a non-invasive, where we don't put any catheter. We just put some dye and do a CT scan, and we can get a very good idea about how much blockage it is. And then if CT coronary angiogram shows that patient has got severe blockage and we need to put a stent in the patient, then we go for that invasive angiogram. And that invasive angiogram, where you put the catheter into the groin or arm veins and then reach the heart just to put the stent in place. So invasive angiogram is not needed to be done initially unless the CT coronary angiogram gives us some kind of idea that this patient has got a multiple blockage. Does it make sense? So we will not straight take the patient for invasive angiogram. We will do a CT coronary angiogram first, and that will give us how much blockage is there. And then if we want to put a stent, then we go for invasive angiogram. Yeah, definitely. In stable angina, you will do non-invasive first. No, you cannot. Remember, this is not MI, guys. Savera. This is a stable angina we are talking about, right? So exercise stress test cannot detect whether it is an anterior MI, posterior MI, because it's not a MI. It is angina. Angina and MI is different. Okay? Angina patient doesn't have pain during rest, whereas MI means patient has got full blockage of the coronary artery, and you need to do something right away. You cannot wait. Management of stable angina. So when we do the management of stable angina, first of all, prevention, because these kind of patients usually have a long-standing comorbidities, which is left untreated, and that usually goes on and on to have future ischemic heart disease. So if a patient is a smoker, they need to stop smoking, reduce the body weight, healthy lifestyle, exercise. If there is any other risk factor like high blood pressure, diabetes, cholesterol, all should be controlled. That is the way we can prevent a ischemic heart disease or AMI in the long run. Let's say someone already developed angina. What to do? So you will be doing all these tests, but in between that, you will also need to manage the patient. So during acute attack, that means when patient gets the pain, you will ask the patient to use nitrate. So they can use the nitrate sublingually, they can use the spray, doesn't matter. Any of the nitrate should do. They should also use aspirin to make sure that the blood starts to get thinner so that it doesn't get blocked up easily. If patient is intolerant to nitrate, nitrate can give a lot of headache. So if patient cannot tolerate that, then we have option of giving nifedipine, which is a calcium channel blocker. So for acute management of angina, the treatment of choice is nitrate and aspirin. Okay. Now let's say that nitrate is not working. So that's the time it becomes moderate angina. So usually mild angina gets better with nitrate. But in case of a bit more severe, which is like moderate angina, you will need to add a bit more. So along with nitrates, aspirin, we also add beta blocker like atenolol or metoprolol, which can reduce any cardiac remodeling, because when heart is under a lot of strain, heart is not getting enough blood supply, it starts remodeling. So to stop the remodeling, we give the patients the beta blocker. So it's mainly for moderate angina, which means that when patient is getting more frequent angina and with nitrate, it's not relieving like before, that's the time we add a beta blocker with it. And if it is a persistent angina, patient complaining like, get like persistent angina, like persistent chest pain, there is always a niggling chest pain there, and you ruled out a myocardial infarction. If it is persistent angina, then we also add nifedipine or amlodipine. So a step-by-step guideline for angina treatment is for mild cases, we just give GTN or nitrate. For moderate cases, that means it's not getting better with nitrate, we add a beta blocker. And if it becomes persistent, even with beta blocker, patient getting angina attack, then we add a calcium channel blocker, like nifedipine or amlodipine. Okay? Usually exam is not very curious about stable angina. They want to know more about myocardial infarction, and they usually test you for those exercise stress test. No, for AMC, there is no requirement of doses. You don't need to remember the doses. Yes, statin and all of those are also important. So again, as I said, that if the patient has got diabetes, you need to control the diabetes. If the patient has got high cholesterol, that has to be managed as well. So those are definitely there. But for angina itself, this is the management. Okay, you are not giving a statin for angina treatment. It's kind of like preventing the other comorbidities. So this is something for, so if a patient gets angina, they will be on this medication. So they will only use the nitrate when they get the pain. But other medications such as aspirin, then beta blocker, if we need to give them the nifedipine, amlodipine, this will be continued. All right. Just the nitrate is something that they need to take it when they get extreme chest pain. Coronary angiogram. So we talked about that coronary angiogram determine whether a patient needs bypass surgery or whether they need a stent. Okay, so as we know that coronary angiogram is the only way that we can be sure that how much blockage is there in the heart. So what is significant? We say that if someone has got narrowing of the coronary artery less than 50%, it is not significant enough for treatment, like not for invasive treatment. Definitely medical treatment will be there, but not for invasive one like stenting. Surgically correctable disease usually begins when there is at least 70% stenosis. We already talked about this when there is 1 or 2 vessel disease, a stent, 3 vessel CABG, and if it's 2 vessel disease, it's still diabetics, bypass grafting. You will get to know a lot about Holter monitoring. And you will see this Holter monitoring as an option in many cardiac questions. What is Holter monitor? Holter monitor is a continuous ECG monitor that records the heart rhythm. So sometimes when a patient comes to us with dizziness, pre-syncope, or maybe even blackouts, and we want to rule out any deep-seated or any undetectable arrhythmia, like you did a ECG in your clinic or hospital, you can't find out anything. But still you think that this maybe when patient is sleeping or maybe some other time patient is getting some arrhythmia. So when we want to find out undetectable arrhythmia in a patient, that is the time we put on this device on the patient. Patient will do everything for 24 or 48 hours, and it will keep on checking the heart rhythm. And it will try to detect any arrhythmia, like could be atrial fibrillation, could be heart block, could be ventricular tachycardia. So if we want to detect rhythm disturbance or arrhythmia, then only we do the Holter. It has nothing to do with coronary artery disease. Very important to understand. Okay? We'll take a break now. I can see many of you are getting confused and asking confusing, unusual questions. Remember, I always answer questions that is relevant, but if you are asking irrelevant questions or something that is not correct at the moment, like if you're asking me that, like, do we need to subscribe for ETG during a class when I'm talking about cardiac pain, that is irrelevant. You should wait for end of the class to ask this question. So I will bypass that question. Okay? So when we are taking a class specifically about a particular topic, ask questions related to that. So that if I need to answer that questions, if you need to subscribe for ETG or what's the course details, then the entire class will be just disrupted. Okay, so it's about understanding when to ask what type of question, and I'm more than happy to answer any questions related to the topic at the moment. And at the end of the class, we will just come into your any kind of questions. How that sounds? No need of remembering any doses. So doses doesn't come in exam. Holter only for arrhythmia. That's right. And Parveen Matthew, yes, you decide medical management or the procedure based on the angiogram. Very good. Heparin has nothing to do with stable angina. We will talk about heparin when we use that. That is mainly for acute coronary syndrome, not for stable angina. Myocardial perfusion scan is kind of a dye test. So they put thallium, which is a nuclear dye, and the dye goes into the heart muscle. And if part of the heart muscle doesn't take the dye, you think that that part of the heart is not getting enough blood supply. That means something is blocked up there. Okay. All right, guys, let me take a 10-minute break. And after that, we will start with myocardial infarction, which is the most important topic for tonight. Thank you. Okay, everyone, let's just start again. So how are you guys going with the class? Are you getting the topic? Are you understanding me? Arjun, class will end most likely in half an hour, hopefully. Okay, let's go on. So we'll go into myocardial infarction. That's the most important topic for your exam. Myocardial infarction means that there is complete blockage of the coronary artery, and there is definitely myonecrosis, which means there is necrosis of the cardiac muscle. And that's why the troponin gets elevated. So you can see that this is how the ST elevation starts to happen. So initially, minutes after having the complete blockage, you get hyperacute T wave. So T wave will be tall peaked, and then you get the ST elevation, and it just changes like this. So you can see immediately after a ST elevated MI, hyperacute T wave followed by ST segment elevation is our finding in ECG. So the question that frequently comes in exam is the management of MI. When a patient comes to us with possibility of a acute myocardial infarction, okay, so you can just tell it as acute coronary syndrome because it can be either unstable angina, it could be non-ST elevated MI, or it could be ST elevated MI. So any of those, when a patient comes to you with acute coronary syndrome, which means chest pain that is lasting for more than 20 minutes, it's not getting better, that is the time we will treat the patient with all of this. So first of all, any patient who has suspected acute coronary syndrome, so this is from therapeutic guideline, ETG, the first thing that we give is aspirin, 300 milligram. So that is the most important medication for any patient who presents with acute coronary syndrome. And this is tested so many times in the exam. So unless contraindicated, aspirin should be given initially for any possible acute coronary syndrome. For ongoing chest pain, so you have given aspirin, but patient is complaining chest pain and patient is hemodynamically stable. Your next option will be GTN, which is glyceryl trinitrate. If GTN does not work, so important things are hemodynamically stable. If a patient is hypotensive, like let's say their blood pressure less than 90/60, and if you give nitrate, it will make it worse. So you can't give nitrate in a hypotensive patient. You cannot give nitrate if a patient is on Viagra or sildenafil and they have taken the Viagra in the last 24 hours. So two things is very important before giving the nitrate. One, how is the blood pressure? And are you on sildenafil or Viagra? Even after giving the nitrate, there is persistent chest pain. Then you go for opioids. And the most common opioid that you can offer is either fentanyl or morphine. And then also, if the patient's oxygen saturation is less than 92%, then you will start the patient with oxygen. Not every patient with acute coronary syndrome will need oxygen. Only if the pulse oximeter saturation shows less than 92%, then you will offer oxygen. Clear? So step-by-step approach. So aspirin is our priority. Managing the pain, our priority. So GTN followed by any of the opioid, could be fentanyl or morphine, and oxygen if the patient saturation is low. That is, this 4 is our first treatment. Okay. Now, based on the nature of acute coronary syndrome, we will manage the patient accordingly. Let's say we have got a patient with ST elevated MI. Yeah, monotherapy. So in a patient with ST elevated MI, as you can see, the therapeutic guideline is very strict also about it. Give aspirin. After aspirin, our next step for ST elevated MI is, as soon as possible, take the patient to the catheter lab for a reperfusion therapy, which means anything to dissolve the clot that is blocking the heart arteries and restore the blood flow. That's what we call reperfusion therapy. Few things are important. So we say, according to therapeutic guideline, reperfusion is recommended if the patient presents within 12 hours of onset of chest pain. So ideally, if patient comes within 12 hours of chest pain, then taking the patient to the catheter lab is indicated. Okay, so within 12 hours of onset of the chest pain, if patient comes to your hospital, then reperfusion treatment is important. And what is reperfusion treatment? It's the percutaneous coronary intervention. Okay, which means basically putting a stent if needed, or angioplasty. So in percutaneous coronary intervention, or PCI, it's a minimally invasive procedure. So what we do, that we will insert a catheter through a blood vessel, so through either from the femoral vein or from the wrist. So we go into the either through the groin or through the wrist. We will insert the catheter and go to the heart, and then we will find out where exactly is the blockage. Then we will push away all the fatty plaque that's blocking it, and then most likely we're going to place a stent in that blocked artery to keep it open. That's percutaneous, because we're going through the skin, right? Percutaneous coronary intervention, PCI. In a normal way, it is just putting a stent, but it has to be done straight away, or like as soon as possible in this group of patient. So if a patient presents to us, and remember, it is only indicated for ST elevated MI, not for non-ST elevated. So if patient comes within 12 hours of onset of the chest pain, then we have an option of doing the reperfusion, which is the percutaneous coronary intervention. Now, the only time we will be able to do the PCI is if this question is important to ask: is PCI available within 120 minutes of first medical contact? So the time your patient enters into the hospital, within 120 minutes, will you be able to arrange PCI for the patient? If you can, then you go for PCI. But if you can't, there's going to be delay. Or you are in a rural hospital, and to send the patient to tertiary hospital, it will take 4 hours. Then PCI is no longer work. In that case, the second option is fibrinolysis or thrombolytic treatment, which is your streptokinase, alteplase, reteplase, those ones, right? Before giving thrombolytic treatment, you always make sure that is there any contraindication of thrombolytic treatment. What is the most important contraindication? If you suspect that patient might have any bleeding disorder, or patient has possibility of aortic dissection. We'll talk about some of the absolute contraindication just in a minute, but if there is no contraindication of thrombolytic therapy, then you go for thrombolytic therapy. So this is treatment. This is what we call reperfusion treatment. So we either choose PCI or we choose thrombolytic treatment. And it is indicated if patient comes within 12 hours of chest pain. PCI is only indicated if you can do the PCI within 120 minutes of first medical contact. So do not confuse these 12 hours with this 120 minutes. Okay? Does it make sense to everybody? So Fatima, if it is a ST elevated AMI, patient comes within 12 hours of chest pain, then you can either choose PCI or thrombolytic therapy. PCI, if you can organize the PCI within 120 minutes of first medical contact, which means that the time the patient comes into your hospital, from that time, if you can arrange PCI within 120 minutes, then you go for PCI. If you can't, then you choose the thrombolytic treatment. So apart from thrombolytic treatment or PCI, what else we have? So we will also start the patient with dual antiplatelet treatment. Then we also start the patient with parenteral anticoagulation, which is heparin you were asking about. So a few things are also there, which we will add eventually, but we will talk about it. But this is the most important thing, that when to choose PCI, when to choose thrombolytic treatment. I hope it makes sense for most of you. So this is the dual antiplatelet treatment for ST elevated AMI. So for patient with a ST elevated AMI who is undergoing PCI, or you have planned PCI, you give aspirin 300 milligram orally plus any of the following. So these are all antiplatelet agents. So prasugrel, ticagrelor, or clopidogrel. Just remember the name of them. Aspirin plus any of this. So commonly we give ticagrelor or clopidogrel. So these are the contraindications of thrombolytic treatment. So thrombolytic treatments, the contraindications are active bleeding disorders. Like patient has got bleeding diathesis, you can't give them thrombolytics. Significant closed head or facial trauma within the last 3 months. If you're suspecting aortic dissection, had previous history of bleeding in the brain, or history of ischemic stroke in the last 3 months. And then there are some of these relative contraindications, which you should also remember. So if any of these are there, then we will not go for thrombolytic. In that case, nothing you can do. You will need to send the patient to tertiary hospital for PCI. You can see here, if more than 12 hours from onset of chest pain, reperfusion still can be considered if there is ongoing ischemia, viable myocardium, major complication. Now, this is specialist level thing. This is usually not your thing because you will not decide this. This will come to cardiologist whether this patient needs to be treated or not. But yes, it can be done. It's case by case. One of the important questions that I wanted to ask you, so look at this question. A 70-year-old woman come to the ED with crushing substernal chest pain for the last 1 hour. ECG shows ST segment elevation in V2 to V4. What are you going to do next? So you've got a ST elevated AMI patient. What's going to be your next step? In the exam, you don't get all of these options, but let's see if you can catch the right answer. Yeah, we will need to go for aspirin initially. Now, the next question, the same question, you have given aspirin. What will you do next? After aspirin, are you going to check CKMB, oxygen, nitroglycerin, morphine, thrombolytics? Which one? Remember, for ST elevated AMI, troponin is not must. It's not going to give us any more information. We just discussed that, right? We did discuss this just in a second. ST elevated AMI, give aspirin, reperfusion. So when we are doing management like this, even though, yes, we know that there are monotherapy, which is morphine, GTN, and all, but in exam, if you have got a ST elevated AMI, after aspirin, the next step is reperfusion, which means angioplasty or percutaneous coronary intervention. Because none of the others, like oxygen, morphine, nitroglycerin, is not gonna it doesn't have any survival benefit for this patient. So that's what we have explained here. Angioplasty is associated with the greatest mortality benefit of all the steps listed in this question. Yes, all of them are particularly correct, and we will do all of those for the patient, but morphine oxygen nitrate, it's not going to clearly lower the mortality. So this is one of the tricky questions where after aspirin in ST elevated AMI, you need to choose percutaneous coronary intervention or angioplasty. Okay. Now, late presentation. So this is your question's answer. This is from John Murtag. So what if patient presents after 12 hours of symptom onset? It is not so reperfusion with PCI or fibrinolysis or thrombolytics is not routinely recommended in patients who are asymptomatic, hemodynamically stable, and present after 12 hours of symptom onset. So usually it's not urgent that we will need to do reperfusion for this patient because most of the time the damage has been already done. You cannot really save the myocardium by doing a urgent PCI at the moment. So, but that doesn't mean that we are not going to do anything for this patient. We will do it. So this patient will go for coronary angiogram, and based on the angiogram, we will decide whether the patient needs a stent or bypass grafting. But it can wait a little bit, or even after a few days, this can be done if the patient is stable. Okay, if the patient is symptomatic, if the patient is hemodynamically unstable, or we are getting complications for it, then the patient will go for reperfusion treatment. Fatima, we just answered these questions, right? You got it? Alina, what if, so do not think so complicated that it's not your job to manage that patient, because not everything as a AMC MCQ student you will need to do. You are junior doctors to the examiner. So there are things that will be done by a cardiologist, and those kind of decisions only a cardiologist can take. If a patient has contraindication for thrombolytics and PCI cannot be done, why is that? Why we can't do PCI? If we can, so if patient has contraindication for thrombolytics, we are going to send the patient to a tertiary center for a consideration of PCI. But if it goes more than 12 hours, then it might not really matter. In that case, we will go for angiography, and then based on the angiogram, we will decide the next step. There is always something that we can do, but depends on how fast we need to do it. Which one you did not get, Dev? At least write down what you did not get, because we don't know what you're thinking. Write down like this is the part I did not understand, so that we can answer that. After 12 hours, great. So after 12 hours, that's what you can see in the John Murtag as well, and also therapeutic guideline. Because what happens in most of the patients, within 12 hours, it is possible to save the cardiac muscle if we can do the reperfusion immediately. But after 12 hours, many times the damage has been done. And body has capacity even after that. There are a lot of patients who has like severe blockage, but there is still hemodynamically stable. It's not like everyone dies immediately. So if heart can function with rest of the blood supply, the stability will be there. Patient might not even have any chest pain after 12 hours. So we say that after 12 hours, doing a PCI urgently is no longer required. If patient remains asymptomatic, stable, then we will organize. So let's say that next day, patients can have a coronary angiogram, and based on the angiogram report, we can decide if there is multiple vessel, 3 or 4 vessel have got complete blockage or 70% blockage, then in that case, we go for bypass grafting. Okay, so based on angiogram, we will decide in that patients. So it's about urgency. It's not like you're not doing anything for that patient. You are, but within 12 hours, you have to do it urgently because you still have got the chance to save some cardiac muscle. Non-ST elevated acute coronary syndrome. So what are we going to do for non-ST elevated acute coronary syndrome? Non-ST elevated ACS, it has unstable angina and non-ST elevated MI. So we will give aspirin and then assess the risk to determine the need for and the timing for coronary angiogram. So based on the risk of the patient, we will decide how soon we need to do angiogram for this patient. So we divide them into very high risk, and low risk. So very high risk is someone who is hemodynamically unstable, cardiogenic shock, recurrent chest pain, life-threatening arrhythmia, heart failure. So any of those patients are very high risk. For them, you have to do the angiogram within 2 hours of diagnosis. High risk is patient has non-ST elevated AMI with elevated troponin level. So for non-ST elevated AMI, new ST changes. So even though initially it was non-ST elevated MI, you know that non-ST elevated MI, if you leave it untreated, it will start to become ST elevated MI, right? So the ST is changing or patient gone into cardiac arrest. These patients will need an invasive angiogram within 24 hours of diagnosis. And for someone who doesn't have that, like unstable angina patient, for them you can organize angiogram later on, even like as an outpatient. Okay, so that means for non-ST elevated acute coronary syndrome, after aspirin, we will need to decide when we are going to do coronary angiogram for this patient. These patients also will be on dual antiplatelet treatment, which is your aspirin plus ticagrelor or prasugrel, plus parenteral anticoagulant therapy. Parenteral anticoagulant therapy is the heparin or enoxaparin. So heparin, enoxaparin, or dalteparin, that's the anticoagulant therapy we can use. We're coming into that. So aspirin for non-ST elevated, then dual antiplatelet the same way, aspirin or prasugrel or ticagrelor. So you can see as a whole, the treatment of non-ST elevated MI, aspirin, then, so it's a dual antiplatelet. Then we have anticoagulant, so low molecular weight heparin, which is enoxaparin, heparin and all. And then consider angiogram. And when we need to do angiogram, it depends on the risk. So this is the treatment of non-ST elevated MI. Remember, non-ST elevated MI doesn't have anything to do with immediate PCI or thrombolysis. The immediate PCI or thrombolysis, it is only required for ST elevated MI. Does it make sense for everyone? No, in a non-ST elevated AMI, the CT angiogram is not going to work. You will need to go for invasive angiogram in these cases because it's already a AMI. So CT angiogram only for a stable angina patient. ST elevated AMI also get enoxaparin. So that's what we discussed, remember, in the flow chart. The flowchart with the ST elevated AMI, along with the PCI, we go for dual antiplatelet and also the parenteral anticoagulant. That parenteral anticoagulant is the heparin, enoxaparin, those things. Okay, so that's all the treatment for ST elevated AMI and non-ST elevated AMI. Okay, is it clear for everyone? Do you guys have any queries? Brilliant. You guys are doing really good. So some of the complications of ST elevated AMI. So patient with ST elevated AMI can have complication with heart failure. Then they can go into cardiac shock. They can have pericarditis, which is Dressler syndrome. The post-AMI syndrome. So all of these complications can happen. We talked about Prince-Metal angina or variant angina. So we already know about that. One thing about Prince-Metal angina is that this angina is coronary spasm, and this happens usually during rest, mostly at night or early morning. Going to aortic dissection, we don't really need anything else apart from what I have discussed from this topic. You will be fine with any kind of questions from here. Aspirin, GTN, opioid, that's for myocardial infarction or acute coronary syndrome. So if patient has chest pain, you have to give aspirin. You do not need to confirm the diagnosis of ST elevated AMI or anything. If patient has chest pain, you need to give aspirin. Okay? Because it's the aspirin which will come first and then serial ECG because you have already done ECG, right? So you haven't given the aspirin yet. So you need to give the aspirin first and then you can go for the serial ECG. No, Prince-Metal is not a stable angina. It's a different kind of angina. Management, good question. So Prince-Metal angina is vasospasm or coronary spasm. So you have to give something which can dilate the coronary artery. What dilates coronary artery? Nitrate and calcium channel blocker. So any of them. So either nitrate or CCB will work for this patient. Now, Prince-Metal is not that important. Everything that we discussed is important for exam. Nothing we discuss is like not relevant. You cannot differentiate Prince-Metal with ST elevated AMI until you do the angiogram. So you'll treat the patient as if it is a ST elevated AMI. You take the patient for angiogram. That's the only time you know. Yes, definitely, because ECG can change. So if the patient has got cardiac chest pain, we still do serial ECG, right? So in between that, you need to give aspirin to that patient if it is a ischemic or if it looks like a cardiac chest pain. Patient doesn't have any pain, ECG normal, then no need. It is recorded. No, if it is a relative contraindication, we try not to give the thrombolytics. The thing is, aspirin can save the patients. It has survival benefit. And if you cannot distinguish a chest pain from heart, or if it is coming from peptic ulcer disease, most of the patient who has peptic ulcer disease, they know that they have peptic ulcer disease. And the pain is quite different. But still, in this kind of situation, saving the patient is much more important than knowing that whether it is a peptic ulcer disease or not. Okay? If a patient has got known peptic ulcer disease, or patient has got history of gastric perforation, aspirin is contraindicated for that patient. Unfortunately, you cannot give it to him. But if it's an unknown peptic patient, never been diagnosed, the pain doesn't go with peptic ulcer disease, then you cannot think like that, because aspirin, what if it is a cardiac chest pain? You're thinking that you cannot differentiate it from heart or GIT, but what if it is actually a cardiac pain and you waited 6 hours to give the aspirin? That 6 hours, there has been myocardial injury, which you could have saved with a simple aspirin, which doesn't even cost a lot. That's what we think. Okay? We already discussed about non-ST and ST-MI treatment. Please go through the recording because we cannot go into that discussion again. I'm very sorry. And about the renal topic, we will discuss. As I said, during a particular topic discussion, please do not bring anything else. It just disrupts the class. And that is a request for everyone. Whether you are a batch student, whether you are a student for the free classes, please wait for end of the class to discuss anything related to your other queries, because it disrupts the class. And you should be respectful for the class, other people who are here to join the classes. Okay? You can always send a message, like a personal message. We always talk to everyone. You can send a message to Arshan Ahmed Messenger. You can send us an email. Personal questions, you can always ask personally rather than asking in a class. No, type of acute coronary syndrome doesn't come in exam. Like type 1, type 2, those doesn't come. Going to aortic dissection. So aortic dissection, we know how the pain comes. We know that it's a sudden severe chest pain. The pain has a tearing, ripping sensation, and it radiates to the back. So if a patient comes to us with a sudden onset of severe excruciating chest pain, usually central or midline, but it radiates to the back, we need to be careful about aortic dissection. So if a patient comes to us with aortic dissection, what will be our best or confirmatory test? This comes in exam a lot. So yes, definitely you'll do a ECG. If you don't know if it is heart related, you do a troponin, all the necessary thing, chest X-ray. So you do all. So ECG, troponin, chest X-ray. But if you need to confirm aortic dissection, the best way to do that is one, that you do a CT angiogram, because that can be done right away. It doesn't take a lot of time. And the best, like if you really want definitive diagnosis, that's transesophageal echocardiogram, or TOE. TOE needs anesthetics and everyone, so it takes some time. Can be done next day, but CT angiogram can be done very quickly. So if you have done ECG, troponin, chest X-ray, the next step will be sending the patient for a CT angiogram. If the question asks what is the definitive test or what is the best test for aortic dissection, then you choose the transesophageal echocardiogram. So you need to find out. So there is no best options in here, depends on what they're asking. So if the question asks, like Kirat, if question asks what is the best test for this patient, that is aortic dissection. But if they're asking if they have done some test, chest X-ray, ECG, troponin, what's next? The next to confirm the diagnosis will be CT angiogram. So confirmation can be done with CT angiogram. We do not need a TOE to do that. But questions sometimes say, what is the definitive test? What is the what is the best test? That is TOE, definitely. TOE is the best, okay? Now, we divide aortic dissection. So aortic dissection is basically a tear in the aorta. And there is, you can see there is true lumen and false lumen. In the false lumen, the blood is getting collected. So there are type A and type B. So type A, anything we say that if a patient's aortic dissection starts beyond the carotid artery, okay, so you've got brachiocephalic, the carotid and subclavian, so left subclavian artery. So if the dissection is distal to the left subclavian artery, that is type B. And if it is proximal to this left subclavian artery, like this one, that's type A. And also if it is including everything, so it's like all over the aorta, that's also type A. So it's easy to remember in this way. If the dissection is distal to the left subclavian, that's type B. Proximal to the left subclavian, type A. Now, the management depends on the type. That's why we discussed that. In case of type A is the worst. And the mortality rate is very high for type A. So the only option is surgery. If we can, surgical repair by a vascular surgeon and cardiothoracic, that's the only way. Type B has less mortality. For type B, our initial treatment will be treating the patient's hypertension, because most of the patients with aortic dissection, their blood pressure will be very high. So for type B, our first option will be to control the hypertension. And to control the hypertension, initially we will try IV beta blocker. And the common beta blocker that we use as IV is IV labetalol. If IV labetalol does not work, or it cannot reduce the blood pressure that much, then we can add the IV nitroprusside. Okay? So that's the treatment of aortic dissection. Any questions with aortic dissection? Okay. There are also few guidelines about aortic dissection, which I have added in your note. You should go through that as well. Acute pericarditis. Yes, both cases. So if there is hypertension in type A, type B, reduce the blood pressure first. But sometimes type B, it's not always that we need a surgery for it. Sometimes it can be monitored, but type A, definite surgery. Acute pericarditis. We know about acute pericarditis, so how the pain comes. It's pleuritic chest pain, so pain will be sharp, stabbing, knife-like pain. And the pain, now remember, pericarditis pain can mimic acute myocardial infarction. So sometimes it can be crushing, and it can even radiate to the neck and arms. So it can happen. But important thing is the pain characteristic. Pain is pleuritic pain, which means it gets aggravated by cough. So coughing, deep inspiration, lying flat, all of this will make it worse, and it can be relieved by sitting up or leaning forward. And we can get pericardial friction rub as well. And many times, the patient usually have a history of viral infection before this happens. Other than viral infection, someone who has got connective tissue disorder, such as SLE, rheumatoid arthritis, uremia, so renal failure patient, even post-MI, patient can develop pericarditis. What is the treatment? Pericarditis treatment comes in exam, so you should know about it. So the first line treatment is colchicine, plus you can try aspirin or ibuprofen, which is anti-inflammatory. That's the treatment. Okay? So colchicine will be for 3 months, aspirin or ibuprofen for 1 to 2 weeks. No. In aortic dissection, every chest pain, our first is ECG. You have to do ECG even because you don't know. It can be a MI patient, right? So ECG first, always in chest pain cases. ECG, troponin, chest X-ray, then CT angiogram. Now, costochondritis. So esophageal pain. So one of the other thing that if you think that it is reflux causing the chest pain, we know that how the reflux pain is. It's a burning pain. And patients usually have reflux and all of those. One of the important thing you can do is sometimes you will find out that if you ask them, does the pain have any any relationship with food? They will say, yes, it can get worse with eating, especially hot or cold drink. They can say that it relieves by, sometimes it can be relieved by eating, like for peptic ulcer disease. Okay? And sometimes even by taking GTN or nitrate, it can get better. So it's not always is very easy to differentiate a esophageal pain with a MI pain. So if you're not sure, you will need to rule out myocardial infarction in that patient. And then if it is ruled out, then you can think of esophageal pain. Costochondritis. So there is a musculoskeletal cause of chest pain. So this is something where patient get an inflammation of the costochondral junction over here. So they complain there is pain and tenderness. Sometimes even we can feel a bit of a swelling over here. Usually it will get worse with breathing, physical activity. Sometimes they will be able to pinpoint the area of the pain. So if you find out that patient having a specific chest pain on a specific point, and there is tenderness on the costochondral junction, that is costochondritis. Okay? And treatment is usually anti-inflammatories for that. So that's all about cardiac chest pain class. I hope you guys enjoyed the session. I know it is a lot to take for a session like this, but again, this is one of the most important topic that you will ever come across for MCQ preparation. How to diagnose pericarditis? So pericarditis, if you do ECG, you will get global ST elevation. We will discuss that in the ECG class. Q banks, so you can use any of the Q banks like eMedici, you can use that, or Amedex. So any of those Q banks you can use to solve the questions. For query about the student portal, send a message to my messenger. That's the best way. So we can, usually there is an admin who will help you for any query related to portal. And about that question, I think your name was AAA. So if anything you don't understand, like any particular topic, any topic that, let's say somehow we missed it in the theory session, most of the time those topics will be discussed in the random question solve classes anyway. But still, if it's not, then you can always ask it in the class, especially when we are doing that particular topic or particular class. If you feel that something is not been discussed and it hasn't been discussed at all, you can always ask at the end of the class. We do not allow any change of device. Okay, it's just to protect the student materials. So if it gets stolen or something like that, you will need to show us a lot of proof of that, which is quite annoying. So I'm hopeful that it will not be stolen. The lectures, everything, the lecture notes, the recordings, everything get uploaded to the student portal where you can access everything. Yes, Sajid, you after aspirin, you use the like any of the antiplatelet agents, clopidogrel, prasugrel, or ticagrelor. Muga scan is not needed for this. No notes will be given separately. It is already added in your student portal. No, the next class, the question solve, the random question solve is basically recall classes that will be completely random, not related to this class. So when we'll do the cardiology question solve class, that will be related to this class. And the next class I'm going to take as well. Which treatment is aspirin, GTN, opioids? That's for like any acute coronary syndrome, you will need to give aspirin, GTN, opioid. But remember one thing, that aspirin is the most important thing. If it is a ST elevated MI, after aspirin in the exam, you will be choosing angioplasty or PCI. Although, yes, we give GTN opioids in these patients, but in exam, after aspirin for ST elevated MI, the next step is going to be angioplasty or PCI. We don't need echo to confirm pericarditis. If we want to know if there is a pericardial effusion, we can do an echo, but echo is not must to do to confirm pericarditis. Distal to left subclavian is type B, aortic dissection. Aspirin is contraindicated in aortic dissection. Remember we discussed it is a blood thinner, we cannot give it. No, S1Q3 T3 is pulmonary embolism and very rare, so don't worry about that. Yes, any Q bank, Arjun, any Q bank can have wrong answers. So you cannot rely fully on any kind of Q banks. Sanya, we do not need to know the doses. Random question solve is enough, Fatima. But if you can do the e-medici, it just gives a bit of a more confidence in candidates, but it is not must to do. Hamad, normally what happens that once you subscribe for the course, our admin will send you an email that do you want to get access to the portal right now or you want to wait for the 2 weeks to be finished. You have to send us a reply that yes, I want to get access right now. Then usually you get added to the portal. So if you haven't got the email or if you have got the email but did not reply us back, please contact through the email. So if you send us an email about like I have already I've already purchased the course and I want to get access to the portal, then the admin will give it to you. Okay. List of all topics. There is so many lists, Sunila, that you can't actually have a list of theory because there are hundreds of lists. And we usually cannot make such a big list for this. So many lists. So if you want, you can make it by yourself. When you are doing each of the theory classes, you can make a list of these are the topics that we are discussing. That's what's going to be your list. But you will find out it is a lot. No, Shirley, you do not need to go through anything. For cardiology, everything that we have discussed today, that is more than enough. You do not need to go through anything else. No, you cannot download any student material in the portal, and no course allow that. You cannot pay in your country currency because we are in Australia. We are Australian registered course. So if you are in India, Pakistan, anywhere in the world, your currency will be converted to AUD. Okay, Saida. So you can pay through our website, and if your card usually should be able to convert everything online if it allows the online transaction. AAA is not a part of today's session. Yeah, this PDF is already uploaded in the portal. So you should be able to find it out under the section of cardiology. If you open the theory section, it should be there. If not, then it will be uploaded by tonight. Yes, any international debit card should be like if you have ever done an online transaction, especially on international one, it should work. You do not need to do ETG by yourself because anything that is important from ETG, we will discuss that. All right. All good, guys. That's all it for today. We'll talk again in next class. I believe your next class is with Dr. Rabia, who is one of the other mentor. She's going to do a random question solve session with you. It's going to be a bit difficult because it's all random, but please try to just focus. And remember one thing, that the question solve or random questions are not an extensive discussion about theory. So she's just going to focus on the important thing and move on to the next topic, because we want to solve more questions, and those questions, the theory part will be discussed by me in the theory classes. So do not expect that in random question solve classes, you will get the full theory of that particular question. The random question is about solving more and more questions. Okay. Arjun, you can make small notes from the lectures. It's going to help in the long run. That's how I work, because I have to write down things to remember. It depends on you. If you feel like you need to write down a little bit to remember things, then yes, it's a good idea to write few things, making your own notes, just to one, to remember everything, and second, sometimes it's going to help you during revision. But my recommendation is not to do any notes for the next 2 months. For 2 months, just watch all the recordings, do all the classes, focus on this, because the first 2 months, the note that you're going to make, it's going to be bullshit and you'll never open that because you will just write everything. So after 2 months, you will become a bit of a pro and mature in this kind of preparation. Then start making your notes. Yeah, random questions are recalls. All right, guys, that's it for tonight. We'll talk to you soon again. Have a good night. Bye.